Welcome and thank you for joining us today. This telehealth series is presented by the Now New Mexico Quality Improvement Initiative. This initiative focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. This 12-part curriculum is designed to give providers, nurses, care coordinators, and community members content-specific training and education with opportunities for care consultations around this focus. And today we have three speakers. We have Dr. Heather Pratt-Chavez. She's an associate professor of pediatrics in the Department of Pediatrics with the University of New Mexico School of Medicine, where she's been since August 2010. We have Karen Longnecker, a clinical social worker with the FOCUS program, whose area of practice is infant mental health and behavioral health integration in a medical setting. And finally, we have Peggy McLean, a clinical psychologist and assistant professor in pediatrics and psychiatry, whose expertise is with early childhood and infant mental health. Welcome, everyone.
Thanks for having us.
Yeah, and thanks you guys for coming today. So this is another talk in our section that's really going to emphasize practical applications for encouraging attachment and engagement between the baby and mom in this very fraught setting of neonatal opiate withdrawal syndrome. And so I asked Karen and Peggy to come and do these parts because they work very closely with these families and are doing this kind of practical work every day. So thanks you guys again for coming and doing this piece. And one more thing before we start. So Karen is going to be leading this section, and this part of the curriculum will really fit into all three of our sections of caring for these babies. So we talk about identification of babies in the hospital, observation, and treatment for these babies. So we're going to try to use these skills in all three of these settings for each hospital who is doing each part of the care for these babies.
All right. Welcome, everyone. Let's go ahead and get started. Today, we're going to be talking about infant mental health and maternal engagement. So let's start with just talking about what is infant mental health as a conceptual framework for how it is that we engage in our practice. This definition that you see on this slide is from 0 to 3, and it discusses infant mental health as how a child develops socially and emotionally from birth to 3, how young children experience, express, and regulate emotions, and recover from dysregulation. I want to make a point on this one that newborns are absolutely experiencing intense emotions and trying to recover moment to moment from the dysregulation that comes just from labor and delivery alone, and then in addition from substance exposure during pregnancy. Infant mental health also includes trusting relationships, how it is that children learn about their world, and how it is that they understand how to repair conflict. Infant mental health also encompasses how children learn to explore, play, experience curiosity in their life that starts from labor and delivery and goes all the way up into adulthood. The field in this definition really looks at overall development from 0 to 5. Also really emphasizes that social and emotional development takes place in the context of relationships. What we really want to highlight in this presentation is that the hospital is one of the first places where those relationships begin. Those relationships begin, obviously, with mom and dad and other extended family members, and also with medical professionals that are involved in taking care of this baby. So for today's talk, our key objectives that we're hoping that you walk away today are about providing relationship-based interventions in the hospital, enhancing a baby's social environment, in that environment including the hospital setting, building reflective capacity for medical providers and also for parents, incorporating language that understands the role of trauma, both for parents and also for medical professionals. We know that trauma doesn't discriminate, that trauma happens to all kinds of people in all different kinds of jobs and scenarios throughout their life, and how to plan conversations with the dyad in mind. That's what we're going to be going through today. So in thinking about who is our patient, infant mental health shifts our thinking away from a patient being just the baby to being the baby and their someone. So this is a quote that we use in our field of practice all the time from an infant mental health scholar that there is no such thing as a baby. There is always a baby and there's someone. Babies cannot survive on their own like adults can. They can't take care of themselves, feed themselves, keep themselves safe. So a baby always comes with at least one someone, and potentially more than one someone. At least sometimes we hope that there's more than one someone for them. The shifting in thinking is particularly important because then the identified patient is caring for the dyad, so caring for the parent-child connection, and recognizing that the relationship is the place in which we focus our intervention. That the relationship is where we plan intervention, it's the dynamic that we speak to, and it's what we're caring for on the whole. Do you want to add anything to that, Peggy?
Absolutely. I mean, I think that one of the pieces that the relationship becomes like how we approach any kind of care, right? So if the parent is there as well as the infant, we want to do things that will kind of support that relationship and that attachment between the parent and the child. And so,
okay. So we're going to see a quick video, and that video is going to demonstrate the concept of the child and their someone.
and as we set this video up, one of the things that this video highlights is just how important that parent-child relationship is, right? And how instinctual it is.
Twisting vines of time, you're in their grasp. A staircase to climb, breathing in gasps. The wind only knows what happened to me. Your rose trapped beneath the sea. This I know, I'll never let you down. This I know, I'll never let you down. Bruises on all the trees, echoing sound. If you're down on your knees for the final count.
All right, so in this video, what we're looking at is how these children have instinct around who is their someone, who is their parent, who is their primary relationship.
They've just spent 10 months with their parent, right? Like with their mom and knowing their heartbeat, right? And so we see these little ones who are older in preschool age, but what we know from infancy research too is that newborns know who their parents are. They've just spent 10 months knowing the rhythm of their mom's heart rate, right? 10 months knowing extended family members and their tone of their voice, right? And so even with newborns, we know that that is also the case, that they know who their caregivers are.
Right. They know their scent, they know their touch, they know their tone. And the video is something that demonstrates that and helps us remember that, that starts in pregnancy and goes all the way through childhood. Okay. So as we plan interventions in the hospital, and keeping in mind the concept of infant mental health and the relationship being the patient that we're caring for, we plan interventions asking ourselves these questions. Who is this baby and who is this parent? That there's openness and curiosity in both of those questions. And then more importantly, who is the baby to the parent? How is it that the parent understands this child? What's the meaning that the child brings into this parent's life in this particular moment? You can think about things about birth order, for example, first baby, seventh baby, and what has happened in between. What's the quality of their relationship? And that relationship, especially for a mom, has started during pregnancy. There's already a story being constructed there and a reality that they're living in together. So as we start to care for children in the hospital, how is it we keep these questions in mind? Because it'll focus our attention on the relationship the parent has with this child. We want to be able to support a parent's ability to be in relationship with their baby. So we want to be able to be the type of professional that allows them to start a supportive relationship with the child that supports their capacity and their confidence as parents. So it's important that we understand parental capacity as a concept that we're looking at in terms of the quality of the relationship, listening and understanding parents' concerns, and then helping the parent to help the baby, being able to look at the parent's sensitivity and responsiveness to the baby's cues. All of these things are these moment-to-moment interactions that we want to look at for parents as they care for their baby, and then as we enter into a relationship with the parent in whatever setting we're in, whether it's inpatient or outpatient. So in one of Dr. Pratt-Chavez's other talks, we talked about baby Rose. So we're going to use the example of baby Rose applying the concept of infant mental health. So for baby Rose, born with NOWS, hospitalized 3 days, weaning and showing signs of withdrawal. This is a moment-to-moment interaction between a nurse and a mom. The nurse sees the mom bedside and asks, "How has this been for you?" Open-ended question. It's brief, it's concise, and it's welcoming. Mom starts to tear up and says, "It's been awful." She answers in a way that's concise and honest as well. So she mirrors a little bit of that affect that the nurse started in that interaction. The nurse listens, and mom talks about how guilty she feels. That conversation can go on for a while. Mom and nurse talk while the baby sleeps, and the nurse learns that mom is struggling with a lot of shame about using drugs during pregnancy, additionally shame potentially for being in treatment during pregnancy, and worries about stable housing after the hospital stay. The nurse gets a little distracted, starts worrying about discharging baby home, given mom's statements, what's going to happen for this baby in the home, is it stable enough for this child who's currently really fragile? But she decides to hold off and not go where her mind had gone and just see where mom goes next. So she takes some time to just reorganize her thinking. The baby wakes up and mom pauses and looks at her baby. The nurse offers to help mom pick up the baby for some skin-to-skin time. They had a shift in that conversation and they started to work with the baby together. Mom agrees. Nurse and mom work together on some positioning. They both get comfortable. Nurse asks mom for permission to speak with the unit social worker about their conversation, and mom agrees. As the nurse walks away, mom and baby are quiet and sitting in a rocking chair doing some skin-to-skin time. In this particular interaction with baby Rose, the nurse used a relationship-based intervention strategy by applying these particular practices that you see on this slide. She asked an open-ended question. She had active listening capacity. She used an empathetic response to the experience of shame, which we know is really common with prenatal substance exposure. She helped the parent help the baby instead of helping the baby and leaving the parent out of that interaction. She obtained consent to release information, even though in this scenario, a lot of care teams are talking about the information that they receive from parents, but in this particular situation, the mom knew that that information would be shared because she had given consent for it to be provided to another professional. And she offered a safe, non-judgmental relationship. That safe, non-judgmental relationship will allow the mom to feel more confident in being able to care for her baby. All right. In our second objective, we're going to talk about the social environment for the baby and the parent. In the hospital, the environment is full of different types of interactions for this child. Nurses, techs, doctors, family members, other babies, social service workers, just to name a few. I know at UNM, it's a teaching hospital, we have even more people in and out. So the social environment for this child is really full of different interactions. What we want to think about using an infant mental health framework is how is each of these different providers influencing the baby, the parent, and their relationship? How do the interactions with every level of professional support the parent-child relationship? What we want to start thinking about are risk factors and protective factors. We talk a lot about risk factors and protective factors in healthcare. I thought it would be helpful for us to just define them. Risk factors, characteristics at the biological, psychological, family, and community level. So you can think micro all the way up to macro and cultural level that precede and are associated with a higher likelihood of negative outcomes. Protective factors then, on the flip side, are characteristics that are associated with a lower likelihood of those negative outcomes that reduce a risk factor's impact. Obviously, prenatal substance exposure being one of the largest risk factors that we're looking at in this curriculum. Protective factors may be seen as a positive countering event. So here's some possible examples of risk and protective factors in the hospital. There's a long list, there's lots of things here, and I'm sure that as you think about these, there's going to be more that you could add to this list.
And one of the things that is important is we often think first about the risk factors. That's normal, right? Because we think about safety and stability, and we want to make that a priority. And so absolutely thinking about what are some of the risk factors in the diet that we want to kind of keep in mind, especially as we're starting to plan discharge and so on. So ongoing substance use, history of trauma, lack of resources, and so on. But we often don't spend as much time thinking about what are the protective factors that we want to support too, right? So if you see a family who's very engaged, right, who has an extended family member that is really supportive. And so spending as much time thinking about like what are the protective factors that we want to leverage, right? And we want to think about as we're supporting this diet. But we often think of risk, we don't as much think about protective factors.
Absolutely. One of the things that could be on either side of this list that I also want to highlight is a family's experience in social systems at large. The families feel like they've been successful in social systems. You can think about benefit systems. You can think about the healthcare system. You can think about relationships with just professionals in general that are for community resources. If families have had positive experiences in that realm, they're going to carry that into the healthcare setting. And then the opposite is also true. If where social systems have not been trustworthy, that's going to play out in the hospital as well. That's when we have a lot of influence to be able to change, especially once a baby is born. So common barriers for families to get to the hospital, where we can start thinking about looking at protective and risk factors and how to support the dyad's ongoing capacity. These are barriers when I was working in the hospital that sometimes I think I took for granted and had to learn to be able to consider for a family system. Inadequate transportation in our state is a huge barrier, especially when families are living in remote areas and need to come to the hospital to do cares for the baby. Going into distance and how it is that families plan for travel. One of the things I wanted to think about a lot when I was working in the hospital was how it is that they're caring for older children. So we just passed the first week of school, and that will make a huge difference in a family's changing routine and how it is that they can care for a baby in the hospital while they look at caring for older children that may or may not have childcare and may or may not be in school. Lack of financial resources, as we know in New Mexico, is a huge barrier for many families. Lack of time off from a job, whether families have parental leave, which is a scarce benefit, I think, across the country, and if their employer is not flexible with them being away from the job or they're in school. Family pressure to be home and take care of other family members if they're taking care of grandparents or taking care of younger children that may not be biological children. All of this can really impact how it is that they can spend time with their baby in the unit. Do you want to add anything to that?
Well, I think it's important that when we see that a family is struggling being with their baby in the unit, or they're stressed, or their care teams are taking note of that the mom hasn't been here for days, or that the the dad is stressed, or that they don't feel like they are having good communication with the family at the bedside, is that we step back and think through this list exactly here, and ask very specific questions. How are you getting to the hospital? Does your family have a car? How far away do you live? Because the more specific and detailed questions you ask about these issues, the more information you can get, and maybe there is some resources we can offer. Bus passes. We can
gas vouchers.
Gas vouchers, yes. We can let the parents know that it's okay if they need to go home and be at home at night with the older children, and only be in the hospital during the day with the baby, and reassure them that they need to do what their family is capable of and caring for the baby. But instead of assuming that the family is not engaged, is to address these barriers and ask about them.
And one of the things we see a lot at UNM is that that highlights the importance of caring for babies in their community, is that as little ones are being transported to another hospital, we're moving them away from their systems of support, right? And we're also adding these risk factors to actually caring for the baby too. So it highlights, and it also reinforces kind of the importance of how do we care for little ones who are at risk for now in their community, and near their protective factors.
Absolutely. Infant mental health interventions support the protective factors and aim to reduce the risk factors. So in line of what we were just talking about, Heather talked a lot about addressing or eliminating barriers. And addressing them, I think it's a really good point with instead of the line of thinking is often, how come you're not here? Right. Instead of, how far away do you live? How long does it take you to be here? Does your family have a car? Those are more detailed questions that get us to specific answers that can get us closer to solutions. This supports the parent's capacity in being able to care for the baby. Protective factors when they're in the unit with their baby is working to support that parent's ability to read baby's cues, building up maternal and paternal confidence, and connecting families with appropriate services and treatment. So the two can go hand in hand. What we're hoping for is that we can identify risk factors, aim to reduce them, and then while we're doing that, we're increasing protective factors at the same time. We're going to utilize the social environment to support newborn regulation. We've talked a lot about newborn regulation in terms of how we do treatment for neonatal opiate exposure, and this is in the same line that we want to reduce stimulation of physical environment to increase that newborn's capacity to care for him or herself, to do some self-regulation in moment-to-moment interactions. We want to teach parents to implement predictable care routines in the hopes that parents will have a predictable routine with their baby when they go home. We want to help parents access resources, and we want parents to feel that they can trust people who are helping them get those resources, having that positive relationship with families so that getting resources and obtaining them and utilizing them feels like a trustworthy process. All right, we talk a lot in infant mental health about the role of reflection, both for ourselves and for parents. We talk about reflective practice for medical providers and reflective capacity in parents and family members. With this overall concept, we have two main goals. Those goals are utilizing reflective practice in our work. Oftentimes in high-stress healthcare environments with a high trauma exposure, there's a lot of talk about self-care. This is not self-care. This is how do you do reflective practice and moment-to-moment interactions. Sometimes for me, it's in second-to-second interactions that you really have to activate your reflective practice methods in going from one patient to the next patient throughout the entire day. Additionally, we want to support the parent's ability to think about their child's experience, so some perspective taking for the parent. The reflective practice for ourselves who are working with families with substance use history, trauma exposure, and a lot of risk factors is thinking about thinking. We want to be aware of our own feelings, values, beliefs, and how we're activated by the families that we work with. So what are our personal experiences? What are our personal opinions, judgments, hot buttons, fears, and triggers? And what does it bring up for us? I don't think any of us come to the table without some experience that is going to be triggering for us. Reflective practice in action for ourselves is the ability to check in with yourself, to know what your triggers are, or to just be thinking about what they might be, to slow down responses, to take that other person's perspective. How would this be for me if I were in their shoes? And to utilize empathy over judgment in conversations with families. Some techniques for medical providers. So in addition to this talk, we have a handout with a list of some active techniques that you can utilize in your practice. It's a one-pager that we're hoping that you are able to refer back to. So before your interactions, pause for an intentional breath. Just a quick second to center yourself. When you notice your frustration, ask another question. I use that one all the time so that I don't go into my frustration. I continue to ask for information. And typically what I find is that the more information I have, the more ability I have to be able to connect with that family. When you're feeling anxious or stressed, allow yourself to take a break. Extend some silence, even if it's awkward, and don't rush to respond. And when you're confused or overwhelmed, ask for more information. Reflective capacity, and this is shifting from if we use reflective practice in our work, how is it we understand building that reflective capacity in a parent? So this is keeping the child in mind, having perspective taking of what is it like for my baby in this moment. So here I have two examples of what mature reflective capacity and some developing reflective capacity look like. So a mom who says, I think I'm feeling really anxious right now, and maybe it's making my baby anxious and upset too. If you've ever watched a baby be passed around a room between different relative caregivers, you can notice that for some people who hold babies, babies are really uncomfortable. And for some people who hold babies, they kind of melt. And what is it that's happening? What is that baby sensing? So we want parents and caregivers to have reflective capacity to say, what am I bringing to this interaction for this baby? And developing reflective capacity is a mom who says, I don't know what's making my baby so upset. He's not dirty and he just ate. But in that particular example, what we want to do is help that mom flesh that out. What might be happening for this baby? What might be happening for you?
One thing that is important to remember too, especially with little ones who have prenatal substance exposure, is that as we're supporting parents and being able to reflect on their baby's experience, that may actually bring up some feelings too, right? And to be kind of supportive and to hold that as possibility is that as they think about their baby's experience, that may also bring in some of the guilt and shame, and how do we approach that with empathy and kind of kindness as well.
Absolutely. Here are some concrete questions that you can use. These are also on your handout as well. So what do you think your baby is feeling right now? How would you describe your baby today? This one's really nice because it allows the baby to change and allows the baby to have good days and bad days. And we all know we have good days and bad days. And we want that to be a reality for our children as well. So what are 3 words that describe your baby today? And then 2 days later, what are 3 words that describe your baby now? How do you think, what do you think your baby may need right now? That's a good one because then it offers a variety of responses. That instead of thinking that babies only need to be changed, fed, and held, or a pacifier, that perhaps they need a series of things and that each baby can be different and have different kinds of needs. After a particularly positive or challenging experience, one of my favorite questions to ask is, how was that for you? It highlights things that are really positive for the parent and keeps them in their active memory. And then for interactions that are more difficult, taking apart the emotionality from those experiences is helpful for processing for parents. How do you think that was for the baby? Gives the baby the same experiential capacity as the parent. Also takes away the idea that babies may not have total memory. We actually want parents to believe that babies remember how it is they're held and cared for. And we know that they do. They learn patterns. And the research shows us that they can adapt to a particular pattern of caregiving And so taking away the idea that, oh, babies won't remember anything that happens to them at this age. And then lastly, what would you like to remember most from our time together today? What do you want your takeaway to be? That allows parents to have some active conversation about something that was meaningful for them, that was either said or felt or experienced.
One of the really nice piece, if I may say, around asking that question is that, especially when you're trying to teach parents something, right? Like if you're trying to help them feed the baby, right? It allows you also an opportunity to do two things. One is to check in around what did they take away from that interaction, right? Like, what do you remember from we spend a lot of time like teaching, like feeding. What do you remember about what we did, right? So it allows you, but then it also gives you this window of curiosity, right? Often what we think a parent will remember is completely different than what they remember. And so in terms of it helps you in your practice of knowing and checking in with a particular family around like what is important to them, because you'll build some themes around that. So you can do it in terms of their experience as a baby, but also when you're actually doing teachable moments with them as well.
Every time I've used that question, I've realized that what I want them to remember is completely different than what it is they're actually going to remember. And that's helped me plan the next interaction with them. Understanding the role of trauma in these day-to-day, moment-to-moment interactions in the hospital is extremely important. We know that trauma and substance use go hand in hand, especially for women. So in the program where we work, we did a study of how it is that moms reported their history of trauma. This was at intake, and I think it's important to note in this particular statistic that this was before a mom had a solid relationship with the person that they were working with. So before their home visitor or their therapist or their provider became a trusting person in their life, they reported, of our moms in our program, over 75% reported a history of sexual or physical abuse at intake. So if we're looking at the mom's adverse childhood experiences and the likelihood that she comes to the table with an extensive history of trauma, we want to keep this in mind to be able to support her ability to care for her child, knowing that pregnancy, labor, delivery, and birth on its own can be really traumatizing, and then adding substance use and history of trauma on top of that is going to aggravate her own history for her. Addiction, trauma, and the attachment system are also going to be really connected, and they're going to all impact each other. So trauma impacts how it is that the parent sees themselves, how it is they've interpreted the trauma that's happened to them in their life prior to this baby. Then it's going to impact how it is that they see their child. Do they feel that they deserve the child? Do they feel that they're worthy of being able to parent the child? Or was the child a planned pregnancy, for example, is another thing we think about. And then trauma impacts how they understand relationship. Who was it that was involved in trauma? How does that tell them how that they can engage in relationships with adults, with family members, with healthcare providers, and most importantly, how they engage in relationship with their child?
One thing that's important that I talk a lot about with our trainees and our staff is that you may actually never know what their trauma is, right? Mm-hmm. And so, and that's okay, but if you hold that as a possibility in the back of your mind, that they may have experienced really hard experiences, it helps you understand behaviors sometimes that are hard to understand, right? And so again, the goal is not necessarily to understand their trauma, right? But is to just hold that as a possibility, and it can really help you have a different lens to understand sometimes confusing behaviors that may come when stress is there.
Absolutely. Substance use and trauma's impact on parental behavior. This particular slide looks at a study of what happens without intervention. So this is what we are hoping to avoid. Without intervention, we can look at a higher risk of a disordered parent-child relationship. A parent that is less responsive to their child's cues, less sensitive to those cues, so their ability to read and respond to those cues is changed. They can be less engaged with their child, less interaction, less face-to-face time, eye contact, mutual gaze, reciprocal interaction with the baby, and they can show less positive affect. So this is without intervention, and what we're working towards by incorporating an infant mental health framework into these intervention, into the hospital and into outpatient settings, is to take away the impact of trauma and substance use that would result in this and be able to have a more positive outcome on the other side.
On a practical level, when a baby is in your care, there are little things you can do that can help with those pieces, being a parent's responsiveness and sensitivity to cues. You can help them understand cues, right? That's helping setting the stage for improving those outcomes, right? And as well as engagement was one that we see in research as a higher risk of having less engaged kind of interactions. You can support them in beginning to be engaged with their child in the hospital and feeling comfortable doing that. So even if you're not, long-term with this family, these little things that you can do that can actually help set the stage for longer work.
Right. So if we teach the engagement and the participation, and we teach the positive affect with the child using relationship-based interventions, then we can kind of pull away from what it is that we've seen as what might happen without intervention. And just to reiterate again, that relationship-based interventions work to support this ordered, attuned, and positive parent-child relationships, this back and forth that feels positive and natural for the child and feels uplifting and joyful for the parent, even when trauma plays a role.
And it's very uplifting and joyful for providers as well to do this type of care. And I really want to emphasize on your slide where you had without interventions, we have those kind of negative shutdown parenting features, and it feels very hopeless. And we hear the data about adverse childhood experiences and their long-term impacts for children through their whole life. And so this is where if we do these subtle relationship-based interventions for these families, we feel like we're setting a positive future for these children. So that's really what I want that red piece there on this talk. This is something that we all can do when we're caring for these families and can mitigate some of these negative predispositions or risks. When we have the risk and protective factors, we can mitigate some of these risks with these interventions. So it is very hopeful scenario for these families.
So what we're hoping for is that we have a presence of mind about trauma, that we suspend assumptions, that we remember the connection, and that we recognize our own reactions to trauma, as those will come up for us when we least expect it as well. Trauma-informed interventions, this is the outcome. They make a space for a new narrative about the child. Parents will often have a story about their child, how their child came to be well before labor and delivery. So if we use these types of interventions, we allow for openness and curiosity for that story to change, and that there can be a new narrative about who this child is and their meaning in the parent's life and their place in the family system. Can connect the parent with ongoing support for unresolved trauma. This is a piece with referring for appropriate services when necessary, so that parents can work through what it is that's coming up for them. It's important for us to remember that pregnancy, labor, and delivery can be traumatic experiences too. Every time I've ever asked a woman for her birth story, there's always something that sticks with her. Even if it was the healthiest and most powerful labor and delivery, there's always something that's going to stay in her mind. And for our moms that we're working with that have either been in treatment or using drugs or both during pregnancy, it's really important to keep in mind that this whole experience can be traumatic in and of itself. And this last bullet point on this particular slide is what I like to call a therapy rule. You never open that which you cannot replace with something better. So not digging into trauma, we're not going to know the whole story of a parent's life. Not releasing something that is entirely too painful that you cannot replace with something better. That's a clinical rule for us and our staff, and one that I hope that a lot of people remember. We can be supportive and we can keep these things in mind, without being unintentionally harmful around trauma. We want to shift conversations with families away from being task-based to being process-based. We want to have curiosity and openness with a parent, that there's a process for the conversation that we're going to build over a few days together, or a few months, or in our case, a few years. And we want to have empathy and patience with the child. Those things happen in a process. Those things are not, we started this task and we finished this task today. These types of process-based conversations, they ask and elicit personal experience. Again, how was this for you? And how do you think this is for your baby? I like to talk a lot about respecting consent, even if you feel like it's unnecessary. Would it be okay if I stood here while you changed your baby? Asking for permission. Would it be helpful if I helped you do some skin-to-skin time? Would it be helpful if we talked about breastfeeding again for the 5th time? Whether asking for that consent and respecting that consent is really important for families to feel like they have autonomy with themselves and with their baby.
And one of the things it does is that it reaffirms their parental role. What often happens in hospital situations, especially with prolonged hospitalizations, which may not be the case, is that parents struggle with who is the parent to this child. And so what you're doing by asking permission, by showing, is that you're actually reaffirming that you are this parent's, this child's parent, and I'm here to support you because of the special circumstances, but you are the child's parent, and really reaffirms that relationship.
They get to feel like they're in charge. Yeah. So this is on your handout as well. It's really important. I struggle with brevity. I have to remind myself to say it in one breath. Have clear and concise speech. Check for understanding, even if you think you have it. Do you have questions about what we just talked about? I use that one with patients all the time. I say, do you have questions for me? And if you can't think of them right now, feel free to call me with a question that may come up for you later. Allow time to repeat information. Does all of this make sense? Does any of it make sense? Are there parts that make sense and parts that don't? And is there anything you would like for us to go over again? But taking the time to be able to have the more open conversation with parents, what we're hoping for is that they'll be able to do the same with their child. This part is also on your handout. Using empathetic speech, recognizing how hard it is to have your baby be in the hospital. Allowing time for questions. Do you have questions for me today? And allowing time for reflection. We talked a little bit about what would you like to remember from today? So what would their takeaway be? Sometimes saying nothing while being present is our most powerful intervention, not rushing to fix it. In a process-based conversation, most things fix eventually if we've been able to have the relationship with a parent that is open and safe. Oftentimes, saying nothing allows the parent to come to that conclusion on their own.
I think also normalizing the stress of having a baby in the hospital is really important. So not just that it's hard for you to have your baby in the hospital, it is hard for any parent anywhere in the world to have their baby in the hospital. Yeah. And it's very, very stressful for every single parent to have a baby in the hospital. So everybody in this unit, everybody in this hospital who has a child who's here, it is stressful. Yeah. And normalizing that and generalizing it can be really helpful for families too.
What we have found is that often what happens is, as medical providers assess the baby's health, so the healthiest baby on the floor or so on, the least likely we are to hold on to that may be very scary for the parent, because we're thinking this baby's okay. Yeah, he just needs to gain X amount. He's going to be out really soon, right? But we forget that the understanding what's the parent's experience of the baby's hospitalization is very different if you take a parent experience from a medical perspective, because medical perspectives, providers have hundreds and hundreds and hundreds and hundreds of experiences with hundreds of babies, right? This is the only experience that the parent has had with that baby. And so how do we hold the possibility that even though you know this baby is healthy and is just here for X short period of time,
that may be, for the parent, they may be interpreting that as my baby may die, right? Like, and sometimes that's hard, and we work around kind of helping understand who is this baby to this parent, because we come with a lot of medical kind of knowledge, right? That sometimes that naturally families don't come with, right? So keeping that open.
Absolutely. Okay. Key takeaways from today: keeping things in balance, like the baby that you see on your slides. Infant mental health intervention supports the parent-child relationship first and foremost. A hospital is the child's first social environment. How do we make that social environment supportive to the parent-child relationship? Reflection builds capacity for ourselves as providers and in parents that we work with. Trauma and substance use go hand in hand. And as we work in this difficult field that is very rewarding but also very difficult, how do we plan interactions to support the long-term relationship with the parent and the child?
So, Karen, I was, when we saw the video of the toddlers connecting to their moms, and then we talk about risks and protective factors, I think of the very, very high risk factor parents that I've had interactions with. And this is what I hear from community providers, that these are some of the most challenging dyads to take care of, is a mom who, say, has had very active ongoing use, for instance, shooting up in labor and delivery, who is intoxicated and not present at the baby's bedside, who is very antagonistic to care teams. And I think about I think all of us as providers want to enhance that special bond that we see in that video, but we see these parents who are not in any place to recognize where they're at with their substance use disorder and their capacity for this baby. And do you have some pearls for providers who are affected by these dyads, and what we can do for our capacity and to help parents in that situation?
One of the things that I have to, it's a great question, and it's a huge struggle. One of the things I have to remind myself all the time is that I never know this story. The story that I have made in my mind is actually a story that I don't know if it's true. One of the things we work with in our team is not creating a story that we don't actually have factual basis for, and not believing the story that we tell ourselves. So I've worked with one of the moms that has, I believe, shot up and was shooting up and was intoxicated during labor and delivery. And what I get to see in my position right now is that 6 months later, she's doing really well. And that's not to say that she may be ready for full-time parenting right now, but has good supports in place, has positive family system that's helping with the baby, has treatment, and has had some time for clarity. And we would have never known that story at labor and delivery. That's the piece I have to tell myself constantly. And I hope that that's a pearl for a provider. And that's the first part of it. The second part of it, I think, is thinking about how is a system built around this baby. And what we have to realize is that sometimes babies go home with biological parents, and they end up like a dyad like you saw in the video. And sometimes they don't go home with biological parents. And so then how do we support the people that do care for these particular children in understanding who this baby is, what this baby brings to the table, and how it is we support this baby long term. And I know that we think more about that in discharge planning, but I think it's important in the hospital to recognize that the relationship can shift. That the relationship in the hospital is not with a biological parent because of those safety concerns or not yet ready for treatment. Then how do we identify the relationship that the child will most likely have and support that, and have some openness about that flexibility? Because over the course of a hospitalization, I recognize that can change.
I like how you said not yet ready for treatment. So we could think of those those family members who are still really struggling with active ongoing substance use disorder, as developing their capacity and readiness for treatment. And the idea would be to not close the door for them. It would be to leave the door open so that 6 months later, like that mom you mentioned, there is increased capacity and there is increased clarity.
Yeah. I have never, ever in my life met a parent who wanted to harm their child.
Mm-hmm.
And I don't think that parents ever want to harm their child. I think we mistake ourselves when we assume their intention is to harm their child.
Mm-hmm.
That they want to do right for that child. And for many, many, many reasons, they're not yet ready to be in a place where they can be right for their child.
One of the pieces too is to understand what is your role in this, what you said, the system of care, right? So what we want to do, and especially with women, what we know is that one of the most powerful factors and most predictive factors of sobriety in women is actually becoming a mom.
Mm-hmm.
And that once the baby is born, that's actually becomes the most predictive factor for their sobriety.
Mm-hmm.
And that's really specific to moms. And so one of the things is exactly what Karen was saying is, how do we create a system of supportive relationship and networks for the family so that there's an opportunity for them to be a different way with their baby.
Right.
And understand that it may or may not happen in our timeline. And so for example, one thing is your role, understanding what is your role coming in, and yours is to support that system of care, right? How you approach that mom, regardless of the difficulties that you're showing, is going to impact whether or not she approaches or avoids, right? Or kind of moves away from it. And then also in the reality is your care will be short term, right? Which is stressful because you are discharging them home. And so then how do you make sure that you have a team that's there to continue that work, right? And that can give a lot of hope, because we do know that even the worst case, like in terms of like situations, in terms of like that there is a lot of growth that can happen. And so
Did that answer your question?
Yes, thank you. Yes, those can be some of the most emotional and challenging cases, because I think as pediatric providers, we feel like we have to protect the baby all the time, and sometimes our endeavor to protect the baby's health, we interfere between the relationship between the mom and the baby, because we think we're doing better for the baby by preventing this mom to have access to the baby or to engage with the baby. And I think even if the mom is in deep into substance use disorder and is not at her best capacity right at that moment, there's still ways that we can leave the door open for her to change the state of change on the cycle, right?
Exactly.
Yes.
Absolutely.
Well, thank you so much, Karen and Peggy. I appreciate it. And I feel like these concepts are so important for caring for this challenging population. And I hope that you all get some good ideas on how to increase everyone's capacity in their care. So thanks.
Okay. Thank you.
And thank you for joining us again. And thank you also for the handout for our viewers. And we hope everyone tunes in for our next presentation.